going to be on our website. So if you want to see it in, or if there's something that you missed, you could see the recording on our website. Okay, so tonight we're going to talk about breast augmentation. So as a reminder, I'd be happy to answer any questions about breast implants or anything else for that matter. But please put your question in the chat box and I'll get to it when we're done with the talk. Okay, so this is my self-promotion slide. Why should you trust me? I have training in both general and plastic surgery, so that was 7 years of residency after medical school. I did an extra year of training in aesthetic surgery in Manhattan. So what does that mean? So for a whole year, I ran a clinic on the Upper East Side of Manhattan, and I operated my own patients, but it was under the aegis of some of the most well-known plastic surgeons in the world, literally. So it was a really wonderful experience for me. So I am board certified in plastic surgery, and I am a member of the Aesthetic Society. The Aesthetic Society is a subspecialty society of plastic surgeons that specialize in aesthetic surgery. And I've been in practice now for 17 years. So here's our office slide. We're located in the MedStar building in Bel Air, for those of you that are unfamiliar with our practice. So I'd like to think we have a nice, modern, new office. This middle slide is our staff. I like to think our staff is knowledgeable, but also very approachable. And if all that's not enough to bring you in, we do have nice snacks and refreshments in the waiting room for you. So here's what we'll talk about tonight. First, we'll go through some fact or fiction. Afterwards, we'll walk you through how we do a consult, talk to you about the procedure itself, and then afterwards. So fact or fiction. So this is probably the most common question I get asked. Do you have to get the implants exchanged every 10 years? And the answer to that is no. Where this came from was that in the early 90s, the FDA became very concerned about silicone implants if they were to quote unquote rupture. But back then in the early 90s, the gel wasn't as thick. So there was a little bit more of a concern because if the shell were to crack, then the gel can escape. So back in the early 90s, the FDA withdrew their recommendation for silicone breast implants to be used for cosmetic reasons, but they were always used for breast cancer reconstruction. So they never really went off the market. So they went back on the market in 2006. So that means that they were studied for 26 years. So that was, they've become literally the most heavily studied medical device of any kind over that time. And there's no evidence that they're dangerous to you, even if they quote unquote rupture. So nowadays, rupture is really a bad term because the implants are like gummy bears. You could cut the implant in half and it wouldn't change shape. So the idea of it popping and glue spilling out is really not accurate anymore. So we really should be calling, instead of rupture, we really should use the term shell cracking. So why would the implant crack? Well, it's usually for two big reasons. Number one, tremendous force. Now I should say some patients are worried that if their dog jumps on them or if they sleep on their stomach, that would be enough force to rupture the implant. No, that's not the case. The amount of force that would take to rupture an implant is on the order of like a car accident. The other reason that implants might crack is over time. We know that as the implants get older, the shell gets weaker. So once you get, especially beyond 10 years, the chance of the shell cracking goes up and up over time. So why is cracking really not an issue anymore? Well, it's uncommon. I'm going to show you later that at 10 years, the chance of the implants being ruptured is less than 10%. So it's not very common. And even if it were to happen, there's no consequence to that. You don't look any different. The implant doesn't deflate like it would with saline implants. So the shape looks the same and there's no consequences to your health. So really shell cracking is sort of a benign event. So here, I could have made this into another truth or fiction here about getting routine MRIs. Some patients ask about that. Where that comes from is since the FDA had troubles in the early 90s, now they sort of cover themselves. So they make recommendations that patients should get an MRI 2 years after their surgery and then every 3 years after that. To be honest, there's not a single patient in the country that does that. The reason is because number one, you'd have to pay for the MRI, which is expensive. Insurance won't pay for that. And furthermore, the chance of you picking up on a rupture is very low because like I said, if the rate is only 10% at 10 years, it's going to be very low for the years prior to that. And furthermore, even if you do pick up a rupture, like I said, it's not harmful to you. So for that reason, it's really overkill to get an MRI routinely. Now, why would you want to get an MRI? By the way, an MRI is the kind of the gold standard test to check for ruptured implants. That's why we do MRIs rather than, let's say, an ultrasound or a mammogram. So why would you get an MRI? Well, let's say your implants are 20 years old. So if they're 20 years old, you probably have at least a 20% chance of them being ruptured. So that might be a good reason to get an MRI if you're curious after that amount of time. Or if, God forbid, you were involved in a car accident or somewhere where you suffered a lot of chest trauma, that might be a good reason to look into it. But there's really no good reason to do it prophylactically. So if you remain happy, if you like your size and shape and they're not ruptured and you still like your implants, there's no reason why you can't live your whole life with the same pair of implants. Now, you might hear the implant companies say that they're quote unquote not lifetime devices. The reason why they say that is because the companies don't want you to expect to be able to live your whole life with the implants, but that doesn't mean you may not be able to. So along the same lines, patients oftentimes are concerned that for certain they're going to need another operation during their lifetime. So that's a maybe, I put, because there's lots of reasons why you may need or choose to have another operation at some point, but it's not for certain. It's not for certain. So what are the common reasons for getting a reoperation? You can see here the most common reason is for cosmetic reasons, meaning if the patient's older, maybe she doesn't want them anymore. Maybe she wants smaller. Maybe she wants to be lifted. So that's sort of a catch-all of all cosmetic reasons why a patient may choose to have another operation. So capsular contracture, we'll talk about this later when we talk about complications, but capsular contracture is the bane of all breast implants. This is what we really want to avoid. And you can see about 25% of the time when a woman is getting a reoperation, that's the reason. So what is that? So that means that when you put something foreign in your body doesn't know what it is and it tries to wall it off. It makes a capsule. And that's true of any foreign thing. Like if you had a knee replacement, it's the same thing. If that capsule stays nice and soft and thin, you don't even know it's there. So it really has no consequence. However, with breast implants, the capsule can get tight. And if it gets very tight, it could distort the implant or even could be painful. So in those extreme measures, it might be necessary to reoperate on the patient to address that. So here's rupture. So 13% of the patients that get a reoperation, they're doing it for rupture. So if you were paying attention, you might notice that I just got done telling you that rupture is a benign event. So why would a patient reoperate if the implants are ruptured? Well, here's the gray medical legal area that we've gotten into. Because there was such a hubbub in the early 90s, if we know your implant is ruptured for sure, we don't feel comfortable leaving it in there. But, you know, like I said, if you held our feet to the fire, it's really not dangerous. But having said that, you know, so that there's no question of it causing a problem in the future, if we know that the implant is ruptured, then we would recommend you get it exchanged for a new implant. Implants can cause breast cancer and lupus. I could have named a few other illnesses, but this is the concept of breast implants causing medical problems in your life and or cancer. So that's definitely false. So like I said, for 26 years, these implants were studied, and it's very clear that there's no association between breast implants and any sort of medical disease. And importantly, you might think that because the implant's there, it might obscure mammograms or even cause cancer, but neither of those are the case. Radiologists now are very savvy with breast implants, and they know how to visualize your breast even with the implant there, so it does not delay a diagnosis of breast cancer. So there's two special topics I want to touch upon under this topic. So breast implant illness. So one of the things that happened in the early 90s and why the FDA was motivated to withdraw their approval was there were women that were saying that they were normal, that had no problems, and were healthy. Then they got their breast implants, and then they started to have a lot of typically non-specific symptoms like headaches, trouble sleeping, and joint pain, things that lots of patients could get for various reasons. And then the patient would get the implants removed and then they would be cured. So it's difficult for physicians to make sense of that, because like I said, there's no scientific evidence that says these symptoms are caused by breast implants, but there is a subset of women that would tell you that. So in the early 90s, this sort of concept kind of faded away, but unfortunately, with the advent of social media and Facebook support groups, this concept has sort of resurrected itself, and now it's called breast implant illness, or BII. But like I said, it's uncommon, and yes, there are women out there that would say things like this to you, but all we could say is that there's no science to back up what they're describing. This is a real entity now. This is a very low level cancer that's associated with textured implants. And that's very important, that they're only associated with textured implants. We don't use those implants anymore. So it's really not an issue. So why I'm bringing it up is because it's in the news, and you may hear reports about it that, oh my God, there's a cancer that's associated with breast implants. It makes for good news. But like I said, there's literally never been a single case of breast implants associated with smooth implants, which is what we use now. So when I say rare, there's only 800 cases worldwide. And to give you an idea of how we're not very concerned about it, it's not like we're calling women that have textured implants and saying, oh my God, come in so we could take your implants out. It's not like that. So basically all we're recommending is that you do the things that you would typically be doing anyway, like breast self-exams and mammograms and ultrasounds, and that's really all those type of patients need to do. But like I said, at this point, we don't use textured implants anymore, so it's really not an issue for women that are contemplating getting the surgery. So what about breastfeeding? So there's no question that it's not a problem to breastfeed with breast implants. It's not dangerous for the child. Now, it's difficult to say because about 30% of women cannot breastfeed anyway. So like, let's say you get breast implants and then you can't breastfeed. There's no way to say whether you would have been able to do it or not without the breast surgery. But the studies have shown that there's no difference. It's still about 30% of women that can't breastfeed, and that's true whether or not you had any type of breast surgery, breast reduction, breast implants, or any kind of breast surgery. This is a common question: is there a warranty for breast implants? And that's actually true. So this is the brand implant that I use. They're called Allergan. They also make Botox, and they do cover the implants if they were to rupture for a lifetime, and cover the implants for capsular contracture for 10 years. So they will pay to replace the implants, and also they'll give you some financial assistance to pay for the other costs that are associated with the surgery. So that's nice. And you don't pay any extra for this. They all come automatically when you get the breast implants. So this is a big concern for people. You know, are they going to look fake? And the answer to that is no. I'm very careful to make implants that are exactly what the patient wants and not look fake or obvious. Why would implants look fake? It's usually because of poor judgment on the part of the surgeon. And what I mean is, if the implants are too big for the patient's body, or if, for example, they're under the breast tissue only and not under the chest muscle, which we'll talk about later. If you were to put the implant on top of the chest muscle, it's much easier to see the edge of the implant or the ripples in the surface of the implant. So for that reason, that's a poor technique, and that might be a reason why the implants look very obvious. And the other thing is, you don't have to get giant implants. You know, I think sometimes people think, well, I don't want to get implants because I don't want to be gigantic. Well, implants come in lots of sizes, and we'll talk about this later. And even some of the smallest implants start at 120 cc's, which is about a third of the volume of a can of Coke, if you could believe that. So some of the implants are very modest. So if you're a patient that just wants some added fullness and really doesn't want to jump up cup sizes, there are some modest size implants that would be appropriate. So going on, I have to say, I'm going to show you some photos, but I don't know for sure if these patients had breast implants, but you could see with some of these celebrity photos, like Cameron Diaz, for example, here, you could see in this photo versus this one, they're not giant implants, but you could definitely see that there's some more fullness when compared to her prior appearance. Kate Hudson, similar thing, you know, from this to that. And Taylor Swift. This is a patient of mine. So this patient had 197 cc implants. So these are relatively small implants. I should say the average size implant for the average patient is more on the order of 335 cc. So these are much smaller than average, but this gave the look that this patient wanted. Well, how about this question? Patients that come in and say that they want a particular size implant because that's what their girlfriend got and she looks great. So I want the same size as her. You can't do that because it's impossible to compare one woman to another because there's so many variables in terms of the height of the patient's weight, how wide is the breast, and we'll talk about that, and the distance between their breasts. So a 330 cc implant may look great on your friend, but may be totally wrong for you. So let me give you an example. So here's a woman that was relatively tall and she wanted some increased fullness, and we ended up putting up 475 cc implants, which are fairly sizable. If a woman came in who was 4'10" and 85 pounds, obviously she would look very cartoonish with implants this big. So obviously you can't compare apples to apples from patient to patient. Okay, so let's talk about how we do the consults. So you come in, and I like to say that I listen more than I talk because I want to find out what your goals are. So when I first started doing plastic surgery, I would say to myself, when I was with the patient in the consultation room, I would say, could I do a good operation? But that's not what I think now. I say to myself, can I make this patient happy? Can I achieve their goals? And that's why I need to know what the patient's goals are. And those goals may not be necessarily exactly what I would do, but obviously the goal of the operation is to make the patient happy. So like I say, I listen quite a bit because it's very important, and we'll find out later, to choose exactly the right implant. We don't have to want to go reoperate on you. The other thing, like I said, what I was thinking, it's not just a matter, is the patient physically a good candidate? Plastic surgery and cosmetic surgery is very emotionally challenging. It's going to be a big change to your life. It could change your life, hopefully for the better, quite a bit. So I want to know, are you psychologically up for a change like that? And furthermore, I should tell you, everybody, no matter how old you are, you have to get cleared medically because we want to make sure that you could tolerate the anesthesia. So everybody gets cleared by their primary care physician. If you don't have a primary care physician, we send you to the urgent care center that's in our building, and you get blood work done and a history and physical just to make sure that you could physically have the anesthesia associated with the surgery. So this is exactly the slide I used during the consult. In order to figure out what size and shape and type of implant we use, we answer 5 questions. So the first one, saline versus silicone. Now, there's no question silicone looks and feels more natural. There's no question. Silicone feels like a breast, whereas the saline implant feels like a water balloon. So there's no question silicone looks and feels more natural. And furthermore, the chance of you seeing rippling in the silicone implant or the sharp edge of the implant is much less with silicone. So at this point, since we're getting quite a lot of years away from the early 90s and the problems then, at this point, about 80% of women are getting silicone implants. Now, I should say in other countries, 100% of women get silicone because they never had the stuff that happened with the FDA in their countries. So they never stopped doing silicone. They never made saline implants in other countries. So every woman outside of the United States gets silicone. So how do we figure out the size? Well, we have to respect the base width of your breast. So that's the big measurement that we take, is how wide is your breast. Now, when I first started doing cosmetic surgery, there was only one scale of implants. So as the implant got bigger, it got wider. So you would just measure the width of the breast and you looked up in the catalog and figured out which implant had the same width, and that's what the patient got. But nowadays, there's 4 profiles. So profiles means that for any given width, there's 4 profiles, meaning how far the implant sticks out from the chest and how big it is. So we have tons of options now. For any given width, there's at least 4 profiles that we can choose from. So this is really not an issue anymore because the shaped implants were nice, meaning they were shaped like a teardrop. They were more popular with somewhat older patients who wanted to look very subtle, who really didn't want to have a lot of fullness high up on their chest. But the problem is that all shaped implants are textured because we don't want them to rotate. So the texturing kind of acted like Velcro, so the implant stayed in place. But remember, the textured implants now are associated with that very rare cancer. So it's not worth getting a shaped implant and dealing with the texturing problem. So basically, all implants that we use now are smooth and round. So now we have to go to the incision. So there's 3 incisions that are reasonable. Now, some of you might be thinking, well, what about the belly button? So I didn't put the belly button down because I don't think that's a good approach, because it's very difficult to put the implant in the correct position when you're tunneling so far away from the belly button. Number two, sometimes you have to retract so forcefully in order to get the implant up there that you end up traumatizing the skin around the belly button. You end up with a pretty obnoxious scar. And furthermore, this is only good for saline implants because it's hard to get a silicone implant all the way up that far, because with saline implants, one of the advantages is you could deflate it, kind of roll it up like a cigar and put it in through a very small incision, and then you inflate it with the saline. But unfortunately with silicone, you have to put it in, already inflated, So sometimes the silicone implant may require somewhat of a larger incision for that reason. So for all those reasons, I didn't include the belly button, and I'm getting away from infraoreolar. So infraoreolar, just so we're on the same page, the areola is the colored portion of your nipple, and technically the nipple is just the part that sticks out. So you could place the incision between the areola and your normal skin, and that in theory sounds great because it's right at kind of the junction of your darker skin and your regular skin, and that sounds like a great place to camouflage an incision, and it is, but it's become clear over the years that the complication rate using this approach is higher. Importantly, the chance of you getting that bad thing, the capsular contracture, is higher, so I don't use the infraoreolar anymore. So basically, we're choosing between axillary, meaning in the underarm, or under the breast. There's no question the under the breast is much more popular. It's most camouflaged because it's under the breast. Now, if you insisted that you didn't want an incision anywhere near your breast, we can do the underarm approach, but you have to understand there is a higher rate of placing the implant in a bad position because it's coming from so far away. So you have to know that if you're doing the underarm. And the other big thing is that your recovery is a little worse because your arm is much stiffer than it would have been otherwise. So this is the easy one to describe down here. As far as the chest muscle, we almost always put it below your chest muscle for two big reasons that we'll talk about later. The big one is we want to camouflage the implant with as much of your tissue as possible, because even though the silicone implants are pretty smooth and they're rippling, they're not fit. So we want to cover that and camouflage the surface with as much of you as possible. And that's really more important for women with relatively small breasts, because if you don't have a lot of your own breast tissue, and there's not a lot of tissue to camouflage the implant. So if you have sizable breasts, like let's say you're going from a big C to a big D, it's less of an issue. But we do also, besides the camouflage issue, the other big reason is it helps prevent the capsular contracture, because every time you use your arm or your chest muscle, it massages the capsule and helps keep it soft. So 99.99 times out of 100, we put the implant under the muscle. Okay, so implant types again. So saline, again, is filled with salt water. It feels like a water balloon. Silicone implants are filled with silicone gel. I checked here, silicone looks and feels natural. I would not say that about saline. And like I said, after 24 years of study, I think we could safely say that the silicone implant is as safe as the saline. So again, here's the sizing. So for any given breast width, there's 4 profiles, and different companies name them different things. But Allergan names this, the lowest one, low plus. Now, I guess they didn't want to call it low because that makes you think that it's too small. So they called it low plus. The next one's called moderate. The next one's called full, and the next one's called extra full. So again, this slide, we probably could not talk about this anymore because, again, we don't use the shaped implants. But as you can see, that would give you more of kind of a straight line up here as opposed to the fullness up here. But like I said, we don't do the teardrop anymore. So the incision, like I said, the 3 choices: underarm, here in the underarm, under the breast, which is the inframammary, and here's the under the areola that, like I said, we shy away from at this point because of the complication rate. And here's the muscle plane. So here's your breast beforehand. So this is the muscle, this is your breast, that's the fat under the breast, and then your skin. So if we were to put the implant on top of the muscle, you could see, look how thin this is, especially up here. So you could be looking at skin, a little bit of fat, and then the implant. So it's possible you might see rippling when you put the implant on top of the muscle. So the vast majority of the time we do this, we put it under the muscle, so there's another layer of padding on top of the implant. Okay, so Chrysalix software. So this is a great morphing software that we use because we want to be able to show you what your results will look like before the surgery. And so that way it'll help us definitively say which implant we're going to use. So let me show you with a different screen how we do the Chrysalix. So I loaded up a bunch of fake patients, and so this patient is called Flat, so we'll load her up. Now, I should tell you, one great thing about Chrysalix is it's web-based. So you could get a head start on your consultation by uploading your own photos from home. You could even do it on your cell phone. And that way we could do a virtual consult and I could show you this screen so we could get a head start about deciding what size implants you're going to do without you actually needing to come to the office. So it's great. Okay, so here's the pre-op version of this patient. So over here, we're going to do a simulation of breast augmentation. So this little book shape is the catalog. So we could look up in the catalog for the implant that we're looking for. So remember what I told you about the 4 profiles? So here they are: low plus, moderate, full, and extra full. So let's say we're thinking about doing a subtle thing. So let's go to the low plus. And again, here, this is the breast width. So that's the key measurement that we would measure on you when you come in to see us, and that's what guides our implant sizing. So let's say this patient had a 12.9 centimeters, which maybe is a tiny bit more than average. So let's see. So I use Inspira, which is a little bit thicker than the standard Allergan implants. So smooth again, right, and low projection. So let's see what that one would look like. So that's 260 cc. So again, that's a modest sized implant. So that's what it looks like for her. So we could save it and we'll call it 260 cc low press profile, LP. So we could save that for later. And what if we wanted to compare that with, like, let's say we'll skip the moderate and let's go to the full size and get rid of the low plus. So, and for her 12.5 centimeters, let's go down. Okay, so let's say again, Natrel, Inspira that I like. Diameter, so that's the smooth low projection again, I'm sorry. So let's place this one. Okay. Okay, so here's smooth, cohesive, full projection. And that's 11 centimeters. Okay, so here's what I want. Inspira, smooth, cohesive. So that's the full projection, which is not quite the fullest, but one lower. So you could see for the same diameter, it's much more volume. The diameter is the same, but because it's a higher projection, it's much more volume. So let's click on that. So you can see how the implants got bigger. So let's save that. And we'll call it full projection 415 cc's. And we'll save that. And then we can go over here and load those simulations so we can compare and contrast. So here's 260 and 415, and when we hit load. Okay, so you can see you can spin it around and show different angles. This is a great angle because it's like looking down on yourself, so I think that's helpful. So you can see how the one over here is significantly larger than that one. One nice thing that they added recently is kind of a movement thing, so you can kind of see, like if you're walking around the apartment nude, you can kind of simulate what you would look like, if that's helpful to some people. So that's kind of a funny thing that they added recently, so it could show what they would look like in motion. Okay, so let's go back to the PowerPoint. Okay, so here's some photos. So this is a patient of ours, and why I like this slide is it shows 3 things. So here's her pre-op appearance, and this is her real post-op appearance, and this is what the simulation looked like. So look how accurate the simulation is, pretty close to what she ended up with. So that's obviously key. We want the simulation. It's not just for fun. We want it to, you know, closely mimic what her results would be. So again, pre-op, post-op, and what the simulation did show us pre-operatively. Okay, so when we're all said and done and we did the crystallics and we know what size we want, you're going to talk to this nice lady, Michelle. She's our office manager and patient coordinator. We've been together for over a decade, and she'll walk you through all the details about the surgery from start to finish. She gives you her cell phone, so she's available day and night, as am I, to be honest. We give you both our cell phones, so you don't have to worry about not being able to get in touch with us. So Michelle is always there if you have any questions, and she could walk you through every stage of your surgery. So what about the procedure itself? We do use general anesthesia. That's the safest way to do it. There are some doctors that do it under IV sedation and local anesthesia, but I don't think that's a good approach. You're really not gaining a whole lot when you do it through that approach, and there's a much greater chance that you can be uncomfortable during the procedure. So we always put you all the way to sleep so you're comfortable and it's safe. We do it in a surgery center for a couple big reasons. Number one, it's much more affordable compared to going to the hospital. And like I said, since everybody gets cleared medically, there's no reason to do this kind of surgery in the hospital. You're not going to be sick. It's not a place where you have to be. So it's much more affordable to do it in the surgery center. And furthermore, it's much more private. In fact, depending on the day, you might be the only patient there. So you're going to get some increased attention as compared to the hospital. And importantly, the surgery center is accredited. So what does that mean? Anybody could just open up a surgery center and just say, and hang a sign and say, hey, this is my surgery center. But if it's accredited, that means Medicare's been in there and everything is up to snuff and up to code and everything works and is clean. So if you hear that a center is accredited, that means that it's legitimate. For a few years, we've been using Exparel local anesthetic. So what that is a long-act local anesthetic that we inject into the muscle. Because remember, that's where all the pain comes from, by elevating the muscle. So we inject that during the operation, and it lasts for about 3 days. I'd like to be able to tell you that it totally eliminates your pain. It doesn't, but it decreases your need for a narcotic down to about 2 or 3. The quicker you get off the narcotic, the faster you're going to bounce back to your previous lifestyle. So afterwards, we put a small dressing on your incision and we have you wear a bra. Now, there are some doctors out there that are convinced the bra helps your final shape. I don't believe in that. The bra is totally for your comfort. So if you told me you didn't want to wear it, I wouldn't argue with you. But most patients want to wear it because it makes you feel more comfortable, especially in the beginning. So after 2 days, you can take the dressings off and you're allowed to shower. The sutures dissolve. Like I said, it's unusual to still need the narcotic after 3 days. The restrictions are you could walk right away. In fact, we'd like you to. You could walk and lift light things, meaning less than a gallon of milk right away. After 2 weeks, you could do something with your lower body, like jogging on a treadmill, but you have to give me 4 weeks before you do any heavy lifting or anything with your upper body. So why is it so long? Well, the reason is because remember, the implants are under your chest muscle. So if you exercise your chest muscle too soon, the muscle contracts and it'll push the implant too far down. And that we don't want that because it's not uncommon for that to need a revisional surgery. So the chance of that happening after 4 weeks is pretty low. So you do have some restrictions for 4 weeks. And I know some doctors use a drain, but we don't use drains for this sort of surgery. So what about the complications? We spoke about them a little bit before, for example, capsular contracture, but the way I like to think about it is there's some complications that are true for any kind of surgery, and these are the 4 that can happen with any surgery. So the study that I'm referring to was after 10 years, how many patients had this problem. So bleeding, meaning like if something starts to bleed and creates a collection of blood, that's very uncommon, on the order of 1.6%. Pain that's out of proportion or or needing additional medications beyond the Percocet, that happens about 11% of the time in the study, but I'd say in my hands, in our experience, it's not that high. Again, objectionable scarring in my hands, I would say lower than that. We take great pains to have a nice quality scar, and I take great pains to make sure the implant is exactly in the crease under your breast, at least when we do the inframammary incision, because we want it to be hidden right in the crease there. So the good news about infection is that it only happens about 1% of the time, but the bad news is that unfortunately if the implant gets involved, it's possible that it might need to be removed because all the antibiotics in the world may not be able to treat that. So the good news is it's very uncommon, but if it happens, it might lead to taking the implant out. So what happens in that scenario? Well, we always give antibiotics a chance, but if it doesn't work, we have to remove the implant. then we leave it out for about a month, and then we put a new one back in. So that's not great. There's no sugar coating that, but it's very unusual. So what about complications that are unique to breast implants? So again, this is a percent at 10 years. So capsular contracture is the big negative one. So what happens if you get capsular contracture? It happens about 19% of women, but not all of those women need another operation, because it could be subtle and mild, and maybe the patient is still satisfied and she doesn't want to do anything. But unfortunately, sometimes, like I said, it can distort the shape of the implant, and even in the worst case scenario, it could be painful. So for patients like that, assuming they want to do something, the treatment is to go back to the operating room, exchange the implant, and cut out the capsule, remove the capsule. So that's the treatment. So again, no sugarcoating that. Nobody wants to do another operation, but I'd say 19% of patients overall get it, and the percentage of patients that get the surgery is probably closer to 10%. Rupture at 10 years, like I said, not even 10%. So that's why it doesn't make any sense to get your implants prophylactically exchanged, because that means 90+% of women are getting the operation for no reason, because only less than 10% of them are ruptured. But like I said, if you are one of the 9%, and we do know it, even though it's a benign event, we would recommend you get the implants exchanged. So at 10 years, only about 1% want the implants altered for cosmetic reasons. Maybe they think they're too big or too small. Maybe they think that their breasts are droopy. So that's kind of a catch-all for all the cosmetic concerns, so only about 1%. And we want to keep that low. That's why we go through all the great pains of making sure we know exactly what size implant you want, because we don't want to have to reoperate on you. So that's it for the talk, for the medical part. So I just wanted to let everybody know that for the immediate time being, we're having 2 great specials. We're offering a discount on your surgery, almost $600 off the usual fees. And because we use Allergan, who also makes Botox, Allergan is running a special that you could get 50 free units of Botox for yourself, and also 50 units for a friend. So at our price for Botox, that could be up to a $1,500 value. So that's it for tonight. Thanks for everybody for joining us. I hope you learned something. We're going to do another webinar on tummy tuck, so keep an eye out for that. If you have questions, I'll be happy to answer your questions now. And if you want to do a virtual consult, there's a link on our website. And here's our phone number and Michelle's email. Okay, so I see a question about, first of all, cost. So Michelle will talk to you about the cost. And as far as COVID-19, yeah, so we are not going to do surgery until we get the okay from the governor. So we're not even seeing patients in the office right now. Now we're seeing emergencies, but we're not seeing, like, breast augmentation candidates. So when the governor says it's okay to reopen up, we're going to have a conversation with our surgery center, and I'm sure they're going to have protocols in place when we do start doing elective surgery to make sure that we're being as safe as possible. So right now, we are doing virtual consults, so you can get the ball rolling in terms of your chrysalics and the details of the surgery that I'll tell you about and the cost, but we're not seeing patients yet and we're not operating yet. Okay, here's a question about driving. So what I tell patients is 2 things until you could drive. Your pain has to be tolerable, because even if you're not on the narcotic and you have some pain, it could distract you, and that's not safe driving. So when you think you could drive safely and you're no longer on the narcotic, then you could drive. And I've had patients that were in that position after 2 days, but that's probably the exception. Most patients need about a week before they're in that situation. So let's say after a week you go back to work. Remember, you still have to respect 4-week no heavy lifting thing. So if you do have a job where you have to lift things, you could go back, but you can't do that particular part of your job. So you just have to remember that. So I'd say on average, you can go back to work and drive after 1 week. Okay, so I think that's it. So again, thanks everybody.